Welcome to our 14th video in rapid interpretation of ECG series. Let's talk about electrolyte imbalances and their impact on ECG. Do you remember which part of the ECG wave represents repolarization? The T wave. Now recall, which ion plays a major role in repolarization? Potassium. Normally, during repolarization, potassium moves out of the cell, restoring the resting membrane potential. But what happens when too much potassium is present in the extracellular space, as in hyperkalemia? The concentration gradient between the inside and outside of the cell is reduced, meaning potassium does not leave the cell as efficiently. This leads to partial depolarization of the resting membrane, making myocytes more excitable. On ECG, this manifests as tall, peak T waves, typically seen when potassium levels exceed 5.5 millimoles per liter. As hyperkalemia worsens beyond 6.5 millimoles per liter, the resting potential continues to depolarize, slowing impulse conduction. This results in PR interval prolongation, QRS widening, and eventually, a sine wave pattern, a pre-terminal ECG finding that can quickly progress to asystole if not treated. Now, imagine the opposite scenario, when potassium levels in the extracellular space are too low, as in hypokalemia. With less potassium outside the cell, the concentration gradient becomes steeper, causing excessive potassium efflux from the cell. This leads to hyperpolarization of the resting membrane potential, making the myocytes less excitable. On ECG, this appears as a flattened T wave, and if potassium levels drop below 3.5 millimoles per liter, U wave may emerge, indicating delayed repolarization. Severe hypokalemia, below 2.5 millimoles per liter, can prolong repolarization further, causing ST depression, a prolonged QT interval, and an increased risk of dangerous arrhythmias like torsades de pointes. Both hyperkalemia and hypokalemia can have serious cardiac consequences, and recognizing their ECG changes is crucial for timely intervention and patient safety. Now, let's talk about calcium. Recall what role calcium plays in depolarization? Normal calcium levels in the blood are typically between 8.5 to 10.2 mg per deciliter or 2.12 to 2.55 millimol per liter. During depolarization, calcium ions enter the cardiac cells, contributing to the plateau phase of the action potential. This influx of calcium is crucial for maintaining the action potential and triggering muscle contraction in the heart. So, what happens when there's too much calcium in the blood, as in hypercalcemia? When calcium levels increase, they shorten the duration of the action potential and repolarization, making the heart cells contract more quickly and more frequently. On the ECG, this manifests as a shortened QT interval, which is one of the hallmark signs of hypercalcemia. In severe cases, shortened ST segments can also be seen due to the rapid return of the myocardial cells to their resting state. Now, let's consider hypocalcemia, when calcium levels are too low. In this case, the myocardial cells take longer to depolarize and repolarize. The action potential is prolonged because there's less calcium available for contraction. This leads to prolonged repolarization on the ECG. The most prominent feature in hypocalcemia is a prolonged QT interval, as the cells take longer to reset. The ST segment may also appear prolonged, reflecting the slow recovery of myocardial cells after contraction. Severe hypocalcemia can even lead to torsades de pointes due to the prolonged electrical activity, which is dangerous and can lead to life-threatening arrhythmias. Both hypercalcemia and hypocalcemia disrupt normal cardiac function and lead to characteristic changes on the ECG. Recognizing these changes is critical for diagnosing and managing electrolyte imbalances in patients with potential heart risks. Please keep in mind that some other ions also play a significant role in ECG waveform, but their imbalances are less common. Let's summarize. The primary ions affecting the ECG are potassium, calcium, sodium, magnesium, and chloride. Hyperkalemia, potassium greater than 5.5 millimol, causes tall, peak T waves on the ECG. In hypokalemia, potassium less than 3.5 millimol, the ECG shows flattened or inverted T waves and U waves. Hypercalcemia, calcium greater than 10.2 milligrams per deciliter, leads to a shortened QT interval, while hypocalcemia, calcium less than 8.5 milligrams per deciliter, causes a prolonged QT interval. Hypernatremia, sodium greater than 145 millimol, or hyponatremia, sodium less than 135 millimol, can alter the conduction velocity and shape of the ECG. Hypomagnesemia, magnesium less than 1.7 milligrams per deciliter, can cause a prolonged QT interval and increase the risk of torsades de pointes. Chloride imbalances can affect the resting potential and cause subtle ECG changes, though they are less pronounced than the effects of the other ions. Thanks for watching, see you in the next video.